Well, why don't we go ahead and get started? We've got quite a few folks on now. Thank you guys for joining. All right, anybody want to give this one a go?
Sure, I can try it. Oh, sorry, go ahead, Momina.
Oh, no. Okay. So this one is like, there was these like cavities that I noticed that had what I thought were like a ciliated epithelium.
Okay, good. So what kind of biopsy do you think this is?
Well, it's pretty large. Maybe like an excision.
Yeah, and notice that there's really no epidermis, right? So I'll just go jump to the next one. Here's kind of a traditional biopsy, like a punch. So this one, it was probably some kind of a subcutaneous nodule or something. So once again, we usually think of shave, punch, excision, that sort of thing. But this one, they probably tried to sort of shell out, I would imagine. So we call that a enucleation biopsy. And you're exactly right. You saw some cavities. Can you tell anything about what part of the body this might be from?
It's really hard to tell, but there's sort of all layers of the skin, I guess you could say. Like there's some muscle, there's some spots that could be fat. So I think it's hard to tell, but
Yeah, it certainly looks kind of deep to the skin, and it's got a couple of other features that are kind of interesting. Like, let's see if I can maybe find it here. Yeah, well, I thought that may be cartilage right there. So there may be a little cartilage going on there also. In fact, I think it is cartilage. Here you can see it a little bit better. It's kind of like fibrocartilage. And then you've got muscle that's kind of oriented both longitudinally and it's in cross section here. And then you've got this is skeletal muscle up here. So where in the body, especially if you're rotating with Dr. Agim, and you're dealing with a pediatric kid that may have sort of a subcutaneous lesion, what are some of the, things that you kind of get worried about there when you're dealing with subcutaneous lesions in children, in small children, for example?
I think you can think about like remnants of like a bronchogenic cyst or
Yeah, exactly. Yeah, so this is probably something like that. You've got cartilage, you've got all this muscle. It looks like a cyst in the skin. This isn't an ENT course, so we're not looking at something that's taken like from the tracheobronchial tree, but it's in the skin and it kind of looks like the tracheobronchial tree. So, and we'll look at a higher magnification. You were exactly right when you said that there was a ciliated epithelium, which you can see right here. It's a nice example of that. And then we'll look at another couple of areas. I think there's one here in the center, which is pretty nice too. Yeah, so you see all that cilia right there?
yes.
So yes, you're exactly right. This is basically a cyst, and it could be from one of the branchial cleft remnants. Now, I don't know if they might show you this on the board examination. It's a little bit esoteric, so I kind of doubt that they would. But what's your approach to naming cyst? He says bronchogenic cyst, you kind of just zoomed into that. But what is your approach when you see a cyst? What is the definition of a cyst?
Well, I think about basically just an open space with a lining.
Yeah, good.
And then I look at
Lining. Exactly. It's got an epithelial lining. And what are and how do you tell the difference between a true cyst and something that is cystic, that looks like a cyst, but it's not truly a cyst?
I look at the lining itself, and if it looks like, I guess more like squamous epithelium, or if it's completely encapsulated or enclosed, then I would think more of a traditional cyst.
Well, the even simpler answer, and sometimes it's hard to dial back when you're thinking complexity to get something that's really simple, but the really simple thing is if there's some material in the cyst space. In other words, is the cysts generally have something inside the lumen of the cyst. So they'll have like in the, like a infundibular cyst, for example, will have stratified squamous epithelium and, sebum and that sort of thing in there. If you're looking at an infundibular isthmus catagen cyst, you see that tricholomal cornified material in there. Here you've got some type of material, probably mucin or something that's floating freely. So look for that, because sometimes you can see something that looks epithelial lined, like a hole in the, like the epidermis, so you get like a spongiotic focus. It's really large. It can almost look like a cyst, but it's really not. So you just want to look and see that there's something inside the cysts can help you. But then you mentioned something about the lining of the cyst, and that's really the best way to name a cyst, is look at the lining of the cyst. So this would be a variant of a cutaneous cyst with cilia, cutaneous ciliated cyst, but it's also got some pseudostratified columnar epithelium that you can see here. And then of course you've got all this other background muscle and cartilage and everything. So yeah, this would be sort of what we would call a bronchogenic cyst. But then always look at the lining. So if, for example, if this were apocrine epithelium lining this as opposed to cilia, what would you call it in that case?
Like a hydrocystoma.
Yeah, like an apocrine hydrocystoma. We also see ecrine hydrocystomas that have more of an ecrine, sort of thin cuboidal cell lining the area. And there's probably about, 10 or 15 cysts that we deal with in dermatology. Obviously, the most common ones are the follicular cysts, the infundibular, the so-called isthmus catagen or tricholomal cyst, and then pilomatricoma, which is actually sort of a type of cyst that's involving the matrical epithelium. So that's good that you were able to get this. So it's an interesting little case here. We don't see this very frequently. When I was talking about with Dr. Agem, for example, you get these pediatric midline lesions, like in the, say, near the trachea or the larynx and that sort of thing. You have to worry about like a cyst that may be communicating with the back of the tongue, for example. You can get rests of parathyroid. You can get thymus and things like that can be involved in these various cysts that occur in the neck area, especially children. If you get the little cyst that occurs kind of in front of the ear, those, if you biopsy them, they may show things like this also. It can show little fragments of cartilage, and they're kind of rests of the branchial clefts or branchial arches in the embryo. So I probably learned a little bit about that. I don't know that you need to, know every single one of those, but they might ask a question or two on the exam about that. Okay, who wants to give this one a go?
So it looks like there's a punch biopsy with some activity in the dermis. Zooming in, I saw, oh, sorry, go ahead.
No, that's good. So yeah, punch biopsy. Know what part of the body it might be from?
Yeah, I saw the stratum corneum is pretty thin, as is the epidermis. I was thinking, I didn't see like sebaceous glands or anything like that, but some nerves. So maybe, I don't know, I was thinking like head, definitely not April, not trunk, I don't think, maybe face.
Well, it doesn't really have very many sebaceous glands that you'd expect to see on the face. The most common place we like to take biopsies, obviously, is the trunk or the proximal extremity, something like that. If you have a choice, if somebody's got a widespread inflammatory disease and they have some involvement of the face or the palm or the trunk or the scalp, you're probably going to choose the trunk because it's easier to biopsy, easier to position the patient. You can put a stitch in there, stop the bleeding pretty quickly. Scalp tends to bleed a lot. Putting stitches in the palms, kind of difficult with that thick cornified layer there. So the vast majority of biopsies we get are from the trunk or extremity for inflammatory disease like this. Now, obviously, if you rule out squamous cell or basal in the face, you're going to get shaved biopsies from that area. But this would be probably, if it's just sort of a nondescript dermis like this, most likely trunk or proximal extremity. And then you said there's something going on in the dermis. So what's the pattern of inflammation that you see here?
I felt like the inflammatory cells were trying to make like little nodules, but I thought it was just like an interstitial, mostly in the papillary dermis.
Well, you're right about the little nodular component. So it's nodular dermatitis, like you mentioned. And these nodules have sort of begun to coalesce, at least in the upper part of the reticular dermis, and still nodular down here. So it's probably nodular primarily with some little bit of diffuse pattern superficially. Good. So what kind of cells are we looking at?
Yeah, I saw some lymphocytes and histiocytes, even a few plasma, and then the like amorphous dark pigment. So I thought it was maybe like a foreign body tattoo reaction, possibly.
Okay. So if you were going to talk about the pattern of what cells predominated here, you said you saw some lymphocytes, some plasma cells, and histiocytes. Which one of those cells sort of wins the award for the highest number of cells?
Could you zoom in maybe just a little bit, please, and I can try to discern.
You
Looks
can start here. I'll allow you to go higher, but even at low power, notice that these are not all sort of dark black cells. The dark black material that you identified here, which is correct. When they're kind of pale like that, think histiocytes, and then a higher magnification, and sure enough, they are histiocytes. So good. What pattern of, and when we talk about histiocyte predominating, what do we call that?
like granulomatous.
Granulomatous, good. And which of the patterns of granulomatous inflammation are we looking at here?
I guess it's, I guess we said nodules. They don't really look like they're palisading per se.
Good. They're not palisading. Absolutely. They're not present between and among collagen bundles with a central zone of something in the middle of it. That's good. If we see like a round cluster of histiocytes that are kind of closely packed together with one another, what kind of inflammation, what do we call that?
Are you talking like, you mean like a granuloma or?
Well, it is a granuloma. And you say it's like an epithelioid granuloma in a way, but what do we call the pattern when we get a lot of these little round epithelioid granulomas in the skin?
I'm not sure. Like, I'm not sure if I.
Okay, that's okay.
Really.
Anybody know what we call that? Nobody knows. I'm surprised. Sarcoidal granulomatous inflammatory reaction. So it looks like it's simulating what we see in sarcoidal granuloma, just like we talk about lichenoids simulating lichen planus histologically. When we see these round epithelioid granulomas like this, that form these little features, just these nodular aggregations of histiocytes, we call that sarcoidal granulomatous inflammation, sarcoidal pattern. And that's important.
Hey, Dr. Cockerell.
Yes.
Does it, I was always under the impression that sarcoidal meant that there was not a lot of inflammatory response around the granuloma. Is that
good?
correct?
Take that concept and throw it out the window. So the answer to that is no. You can get some lymphocytes in true sarcoid. In fact, you always talk about so-called naked granulomas in sarcoid. They're really not naked. They still have some underwear on. So you'll often see some lymphocytes in sarcoid as well. It's not purely histiocytes with no inflammation. The main thing about sarcoidal granulomatous pattern is this. You see these nodular aggregations of these epithelioid granulomas like that. So that's sarcoidal pattern. And you can see that with not a ton of diseases, and that's good because once you identify this, you can get the differential diagnosis down pretty small, pretty low. We love it when you get a short differential that gives you a pattern like this. So what are some of the diseases that can do this? What's the number one disease that gives you sarcoidal granulomatous inflammatory infiltrate?
Sarcoid.
Yeah, sarcoid. Right. So sarcoid's the prototypical one. But what are some others that can do it? One we're looking at right here in front of us. You've already made the diagnosis. What's another one that can do it?
Like foreign body granuloma.
Yeah. Like a foreign body. Now, what foreign bodies will give you sarcoidal granulomatous patterns? Not all of them do, but some of them do. So here's one. A tattoo reaction can do it. And it's actually often, it can be, the regular kind of inks that we see, the cinnabar and the yellow and green and all those kind of different colors, the black. It can also be some of those vegetable dyes that people get when they want to tattoo their eyebrows or their eyelids or things like that. We've got a case coming up this year in the Zola Cooper conference that Dr. Davis submitted. That lady had that microblading on her eyebrow, and she developed sarcoidal granulomatous tattoo reaction. And sometimes when you actually develop a sarcoidal granulomatous tattoo reaction, it may actually be in an individual that has an underlying a tendency to get sarcoidosis, and they actually start manifesting true sarcoidosis when they get the tattoo reaction. So we know sarcoid can kind of Kebnerize in some cases with trauma. It can sometimes actually sort of bring about sarcoidosis systemically. And there was a sort of an infamous situation in Dallas probably about maybe 20 years ago, where they had a cosmetics conference up at that World Trade Center and had a bunch of women up there, and they all gave themselves these tattoos, and about 20 women got this kind of reaction, and a number of them, African-American patients, developed polyretinopathy and lymphadenopathy and got really, it sort of precipitated sarcoid. So it can happen. What are some other diseases that can give you a sarcoidal granulomatous histologic reaction pattern? So we said 2, we got a couple more to go.
Crohn's disease.
Good, yes. And any of the Crohn's-like conditions that occur all along the GI tract. So that's good. We'll talk about something along later on in this session if we get there. What else? What's another one that's very important to remember when you see a sarcoidal pattern? You wouldn't think of it as being sarcoidal, but it actually, the histology of it is quite sarcoidal. The name is a fooler. Tuberculoid Hansen's disease. So you say, well, tuberculoid, you think it would be a tuberculoid granulomatous inflammatory reaction. No, it actually gives a sarcoidal granulomatous reaction pattern. And when you see when you try to find organisms in paucibacillary tuberculoid, polar tuberculoid Hansen's disease, it's almost impossible. You almost have to do PCR. And even in those cases, it can be hard to find organisms. So you have to make that diagnosis often on the basis of clinical findings, coupled with, like, they get large nerves and they lose their sensation. What are a few other things that can give you a sarcoidal reaction pattern? There's a couple of classic ones that the board likes to ask about every single year, it seems like.
I mean, the other like foreign bodies I think of are isn't like beryllium or
Good.
some of those other.
Good. Beryllium, zirconium, yeah, those. And they talked about that, I think, gosh, probably back in the 40s when people were working in some of those factories where they made fluorescent lights. I don't think they make those lights hardly anymore. But that stuff would have beryllium in it, and some of those patients would get these injuries, and then they would get the sarcoidal granulomatous reaction. And so a couple other foreign bodies, sometimes silica. So somebody's in an auto accident, they get a piece of glass in their skin, and then years later they develop a sarcoidal granulomatous foreign body reaction. You biopsy it, and it's polarizable material in there. Now, silicone does not usually give you a sarcoidal granulomatous reaction pattern. I think we talked about that a few weeks ago in one of the sessions. It gives you sort of tiny little bubbles inside, and it's more of a diffuse granulomatous pattern. So that one's different. So it's important to know this pattern, because there's not a ton of diseases that can do it, and recognize the pattern. Got a short number of entities to think about. Here you look at it and you see the obvious black materials. It was a tattoo reaction, so it's pretty straightforward. But if you just saw nothing but sarcoidal inflammation, granular dermatitis without any black material, you need to think of some of those other conditions. Okay, good. All right, let's take a look at this one.
I can do this one.
Okay, great.
This is a punch. I think we're on the scalp.
Yes. Why do you think you're on the scalp?
Well, there's a lot of terminal hair follicles.
And where are they located? Where are they located?
Well, they're both in, they're through the dermis, but I don't see necessarily, some of the bulbs are actually in the dermis, which is atypical a little bit at least.
Yeah,
I would think more of them should be situated in the subcutaneous fat, but yes, generally there's terminal hairs that are throughout the layers of the skin here.
Yeah, when you see these big terminal follicles going all around subcutaneous fat, that really strongly favors that you're dealing with the scalp. So that's good. Is this normal here?
I don't think so.
Okay.
I mean,
Okay, good. It's not normal. We never show normal skin in unknown pathology sessions. But why is it not normal? How can you tell at this power that, uh-oh, something's wrong here?
well, I don't know if all of the hair shafts are necessarily the same size, which
Once
you know,
again, it's easy to go to too complex answers when there's really a very simple answer as to why this isn't normal. I'm not asking you what the pathology process is yet. We'll get there, but at least at this power, why can you say that this isn't? It's probably a 4mm punch biopsy. Why is this not normal?
there's not that much hair.
Good. There's few. What's the normal number of antigen follicles that you see in a 4mm punch biopsy from you, for example, from your scalp? You're not bald.
Like, I don't know, 10.
Yeah, 8 to 10. 8 to 10. Good answer. How many do we see here?
4.
Yeah, 4. So this antigen to telogen ratio, and maybe even less of that, may really only be 2. You know, this one may kind of already, this one's already kind of regressing. That one's really small. So we really only have about 2 or 3. So you know that this ratio is far diminished. You know, way too few antigen hair follicles here for what should be present. So you know you've got an alopecia. So if you look at this person's scalp, they're going to have a marked decrease in the volume of hair clinically when you biopsy this area. Okay, so now we're dealing with an alopecia. So we've identified that. So what's your approach, just like we had an approach to dealing with sarcoidal granulomatous inflammation, what's your approach when you're dealing with an alopecia?
Well,
By the way, just so you'll know, this alopecia here,
yeah.
we try to put good cases in for you guys, but sometimes we just have to find the diagnosis that is there based on clinical correlation. This is not the type of one you would get on an exam of this entity, just so you'll know. But we can still work through it, and there are still some diagnostic features, and it's helpful to learn it in this way because in the real world, you don't get the classic features histologically and clinically as you see in our conferences. You know, you biopsy the best thing you can, and we do the best we can to give you diagnosis, but usually if it's obvious clinically, you're not even going to take a biopsy of it. So you're going to biopsy something you're not really sure to try to get an answer. So that's what makes this feel challenging. It's not that we're always you're giving us textbook examples of things. We're giving you textbook examples back. You're getting something that you're not sure of the cause. And we've got to look at this and see if we can come up with the best criteria that we apply to favor something or another. So what's your approach when you're doing that?
Yeah, I mean, clinically, my approach is it scarring or non-scarring, and I think you can do the same thing histologically.
You can, and there's I like to go more inflammatory or non-inflammatory. You know, is it something that's inflammatory that's driving the alopecia? And if it's inflammatory, is it causing, like, you know, scarring, which is a permanent type of alopecia, or is it non-scarring? And then, so this is where you can become more sophisticated than your residents and other programs. What are the 2 types of scars that you see in alopecia? What are the 2 types of patterns of scarring that we see in inflammatory alopecias?
Do you mean the cell types like neutrophilic or lymphocytic predominant?
No, that's next, because either one of those can cause scarring alopecia. You're right about that. But what are the 2 patterns of scarring that we see in alopecia? And this is where a lot of people don't do that. You know, they sort of talk about, you know, oh, it's a red erythema. You know, well, that's sort of not really a gourmet's approach. You know, that's sort of just a gourmand's approach. Same thing with scarring alopecia. Well, there's some different ways you can get scarring alopecia. Where does a scar necessarily occur? And you
I
may
don't
not.
know if you mean like like follicular versus the interfollicular
Yeah,
epithelium.
good. Exactly. Good. Very good. So you can get scarring that's like a rifle shot that targets the hair follicle itself. And then you can get scarring like in folliculitis decalvans, where you get a suppurative folliculitis and things rupture, and it's sort of like an army marching through and just destroying everything in its wake. So those are the two main types of scarring that you can see in an alopecia. So one is really more kind of targeting the follicle. And then you can ask yourself, well, where in the follicle is being attacked? Is it sort of up in this area here, which we classically see with lichen planus and frontal fibrosing alopecia and central centrifugal alopecia? Is it targeting kind of the entire follicle around this whole area, like we see in discoid lupus erythematosus, for example? So it's important to kind of understand the sophistication of exactly where the scar occurs in the follicle itself, and whether it's just hitting the follicle or it's hitting everything away from the follicle. So that's helpful when you're making a diagnosis. So is this a inflammatory scarring alopecia here, or is it possibly an inflammatory alopecia that's not scarring and that the person could grow their hair back theoretically?
To be honest, I don't see a lot of inflammation around the follicles itself.
I don't either.
So I think it's the
I
latter.
don't either. You're totally correct. I don't see any of alopecia here. I don't see any real fibrosis. So no, I think this is a non-scarring, if it's inflammatory, it's going to be a relatively sparse inflammatory infiltrate. It's not going to be something that is like lupus, for example, or something along those lines. So good. So it may be inflammatory. It's definitely an alopecia. And what about the follicles? What stage are these follicles in here? This follicle is still an anagen, but what about this follicle right here?
I actually don't know.
That's okay. That's fine.
Sorry.
It's actually been shifted from anagen. It's like the end stage of catagen, and it's heading into telogen. Okay, so this follicle has been shifted. It was once upon a time, it was an anagen, and then it shifted into telogen. Here we've got another one that's kind of heading away from anagen. It's beginning catagen stage here. It's got a little bit of perifollicular inflammatory infiltrate here. And the reason this is a tough diagnosis is that this is an example of alopecia areata without very much inflammatory infiltrate, which we see on occasion. And would not be one that you would get on your exam. It's too difficult for you to diagnose on a test, but it's what we get in the real world. So somebody comes in with an alopecia, they want an answer. We have to look at it and we say, well, this has got a shift from anagen into catagen and telogen. Usually you don't see catagen follicles in a biopsy of alopecia unless it's alopecia areata or possibly trichotillomania. And if we don't see any like destruction of hair shafts, we don't see any trichomalacia, so that kind of militates against trichotillomania. Usually in telogen effluvium, because there's not that many follicles that are shifted into catagen, you'll just see more telogen follicles, and it's rare to see catagen follicles in that. If you ever see 3 or 4 catagen follicles, and they're all kind of shifted in that stage at the same time, even if there's no inflammation, that's virtually pathognomonic of AA. So we thought this was probably AA. But you don't necessarily need to be super concerned about that in a biopsy like this. Here, this one's maybe got a little inflammation around a couple of these hair bulbs, but this would be an example of a tough diagnosis of AA. But we learned some other things on this case. We learned about the number of hair follicles that you can diagnose and tell it's immediately an alopecia. You learned about the different types of scarring. So those are some of the more important things here.
Dr. Cockerell, can you actually point out some of the features of anagen, catagen, telogen from the 3 that we saw?
Yeah, this one, anagen follicles, you see a hair bulb that's rooted in the subcutaneous fat like this with a nice papilla. So this is a nice example of an anagen follicle here. It's small, but it's an anagen follicle. Catagen, and again, this isn't a great catagen follicle, but you see a thickened glassy basal membrane around the keratinocytes because they're basically dying. You'll see dyskeratotic keratinocytes inside the residual follicle. So this is kind of late catagen, early telogen, this follicle right here. But if you see a classic catagen follicle, you'll see dyskeratotic keratinocytes, thick glassy basal memory zone, and loss of the outer root sheath and inner root sheath of the follicles. It's kind of collapsing in, kind of it's moving into this stage here. And then telogen are just little miniaturized follicles. I'd say this is better for telogen if you're just looking right at this little thing here. It's just kind of a little residual, what we call a stella, a small little primordial residuum of the matrical epithelial cells that are the stem cells that can regrow again when the follicle starts its new cycle. And that's kind of why it's important to distinguish between the permanent and the non-permanent alopecias, especially now that we have drugs that can take people with AA that have got alopecia universalis and they can grow their hair back. So we get a lot of biopsies to exclude scarring from non-scarring alopecias for that reason.
Thank you.
You're welcome. Okay. This is one that I would suspect you probably would encounter on the board examination here. So if it's something that's pathognomonic, they like to ask it.
It's just gout.
Okay, tell us why.
You have this excisional biopsy, most likely. That's why I guess. And you have these collections of this like light purple feathery material that's like acellular.
Okay. So you're writing an examination question, and you want to trick your colleagues that are from another school. You want to make a better grade than they do. So what are you going to put down there as distractors for this? So you know it's gout, but they may not. So how do you want to trick them? What are you going to put down?
Maybe you could put like a hyaluronic acid.
Okay, good, because it's light blue and gray. Excellent.
Yeah.
Wouldn't have the crystal feathery material that you see here.
Yeah,
What
maybe
is this here? What are these cells here?
I think they're a mix of like lymphocytes and maybe histiocytes.
Yeah, that's a multinucleated histiocyte there. So what's going on here?
Like a reaction, like a granulomatous, like foreign body.
Yeah, good. Yeah, the gout shouldn't be sitting in your skin, and the gout crystal shouldn't be there. So your body comes in and says, get out of here. We're going to form a foreign body reaction to it. And it almost looks like a palisaded granulomatous dermatitis a little bit, doesn't it?
Yeah.
And it looks like there might be some hyaluronic acid or mucin in the center of that. So is there some other disease you might want to put down to try to trick your colleagues?
GA, pseudo-gout.
Yeah, granulomedullary, subcutaneous GA. I'd probably throw that in there if I wanted to see if somebody was asleep at the wheel. It's got a granulomatous inflammation with central purplish material that kind of looks a little bit like mucin. Good. What else would you put in there? So you say, oh, okay, it's obviously some sort of deposit. So what other deposits do you kind of have to make sure that it's not? So you got the answer here, but if you're on a real exam and they've got all this stuff on there, you want to make sure that you don't sort of start questioning your answer. It can shake your confidence when you look down there and you see a few other things. You start saying, well, gosh, maybe it could be that. And the next thing you know, you don't answer the question correctly. So what are some other things that they might have on the exam?
I mean, can they put pseudo-gout on there?
I'm not sure I'd go with that one because that can really look a lot like gouty crystals. Oxalosis, that probably wouldn't do that because those look very similar to that. But there's a couple other things they could maybe put down.
I mean, I don't think it looks like that, but other things might be like gel foam or like something calcified.
They could put that and say, well, gel foam, if you don't know what that looks like, you might think that's kind of crystalline like this. What about if they put something like amyloid?
Oh, yeah.
That's sort of amorphous and
yeah,
it is blue. Amyloid's usually pink. What if they put down lipoproteinosis? Do you know what that looks like? Yeah.
Usually they're like more discrete collections, right? Like smaller.
Little rocket ship collections and up in the papillary dermis, and it's again kind of a pink hyalid-like color to
Mhm.
it. So it really doesn't look much like that, but they put stuff like that down. There's another thing called, well, how about colloid milium? Colloid milium. Does that look like this?
They're usually very round.
Well, actually, they kind of almost look like fractures of, so it's like solar elastotic material that almost forms little
Mm.
fractured jello-like collections. And again, usually in the upper papillary dermis, usually don't get a granulomatous reaction around that like this. So, but those would be some of the kind of things that they're going to put on there to try to distract you. So make sure you know what these deposits look like. If you see the this feathery change like this is really virtually pathognomonic of gout, if you will. So that's straightforward if you see it. And they're not going to put things that look exactly like this down as a differential diagnostic, for you. Now they might ask you, does this material, would it polarize? So what's the answer to that?
I think yes, right?
It should, if the gout crystals are preserved in 100% alcohol, and there they look kind of brown histologically, but once you put them in a regular processing with water and it extracts the gout crystals and everything, it often, you're just seeing kind of the ghosts of where the crystals used to be, and they don't polarize. So you kind of have to preserve the crystals if you want to see them in the skin. Okay. This is a fantastic one, and one that you very well could end up with on the exam here.
Looks like a punch biopsy.
Good.
Like a lobular paniculitis. Looks like it's involving the lobules.
Good. Excellent. So you've got an instant way of dealing with this. So paniculitis, lobular mostly. Good. And what's the next thing you do when you've diagnosed it as lobular paniculitis?
Maybe zoom in, look at what type of cells, but even from scanning, it's probably lymphocytes.
Good. A lot of lymphocytes here. And then you also ask yourself, is there vasculitis or no vasculitis?
Okay.
Because there are paniculitides that involve the lobules and the septa that can have vasculitis with it or not. So we always look to see if there's vasculitis. Is there any vasculitis here?
I don't think I saw any.
Good. You did not see any. So mostly lymphocytes. Any other pattern that we see here that's helpful?
They almost feel like some of them are like forming little lymphoid nodules.
Okay. There's very dense. You're right about that. What
And
else
then,
do you notice though here?
is that like fibrin in between or mucin? Mucin.
Yeah, there's definitely mucin here, an abundance of mucin. See that,
Yeah.
that grayish blue material. And then what about the fat itself?
Looks like a little bit of like hyaline necrosis. Some fibrin.
Yes. Yes. Are these lipocytes?
I thought they were.
They're actually fat microcysts. It's sort of like alveoli in the lung when you get emphysema and you get the, those large blebs. The same thing happens in the subcutaneous fat. When you get inflammation in the actual lipocytes themselves, they kind of burst and they form these little small microcyst-like structures. They're not really true cysts, but they're basically an analogous to blebs in the lung and emphysema. So it's no longer the lipocytes, little fat microcysts is what they're called.
Okay.
And that usually occurs when you get an extensive amount of inflammation of the lobules. So what's the most likely diagnosis here?
Not like a lupus, profundus lupus paniculitis, but I think you have to put subcutaneous paniculitis T-cell lymphoma on there with that differential.
Yeah, you put on the differential. You can throw anything on the differential. And so, yeah, that's one thing about, quote, differential diagnoses, end quote. They end up in textbooks and things like that, and we memorize lists. But when we apply them on a particular case, on a case-by-case basis, does this have anything in here that looks like really it's a lymphoma here? This
No.
one case right here today that you're looking at right now?
Not really.
No. And so people talk about that. You'll hear that at conferences. Oh, you always have to worry about subcutaneous paniculitis like T-cell lymphoma. And yeah, you do, but you can quickly stop worrying about it when it's got all these other features. When it's got this extensive fat degeneration, it's got this necrosis of the fat, it's got the mucin. You don't see that in subcutaneous paniculitis like T-cell lymphoma. That's basically gives you a lobular paniculitis with lots of lymphocytes, but usually it doesn't cause the degeneration and mummification of the fat like you see here. And I don't remember seeing a case that's got this much mucin. So when you see that, you can just kind of toss the thing out. It is something that you do want to keep in the differential, but you know, just like anything else, you can put it in there and you can quickly destroy it when it doesn't make any sense. So this is LE profundus. It's not uncommon if you look at the upper part of the dermis in LE profundus that you'll see other features of lupus overlying it. So you get a little bit of a lymphocytic infiltrate left here. You have a little bit of mucin up here. So if you just saw that part, you might think of tumid LE. And it's not uncommon to see interface change and features of vacuolar alteration and whatnot that are also features of lupus overlying the lesion of tumid LE. I'm sorry, of lupus profundus. What percentage of these patients have systemic LE?
Like 10 to 15%.
It's higher, up to 50 to 60% will ultimately end up having some systemic manifestation. So it's kind of a sign of systemic illness. They don't always have to have it, but they often do end up getting systemic findings. So you want to make sure if somebody's got this, that they don't have kidney disease or other things going on there. So it's a beautiful example and good that you had a good way of approaching it.
Can I just clarify something terminology wise, Dr. Cockerell? So if it was just the bottom without any like overlying inflammation, we're saying like they're not really interchangeable, right? So you would say lupus paniculitis, but because there are some changes also in the epidermis and like dermis higher up, you can say profundus, or do I have that wrong?
No, I think it's basically synonymous. I mean, I view the two terms as synonymous. Lupus profundus, LE paniculitis, same sort of thing. It's just very common to see some features of typical LE overlying it. I'd say probably in most cases I've seen, there's some change overlying it that still gives you features of lupus. And that's helpful in the diagnosis as well, especially when you may get the case where the differential is really significant for subcutaneous lymphoma. This was kind of a fun one. Anybody want to do this one real quick?
Sure. I'm at a stoplight. So it looks like a
Oh,
shaved
I'm not.
biopsy, possibly April. And
Yes.
initially it looked kind of normal to me. So I started going down kind of like the normal mimicker things. And I saw some pigmented hyphae just in the stratum corneum. So I thought awesome.
You're kind of cutting out a little bit, but I think you said everything correctly. So yeah, the diagnosis here is Tinea Nigra. Okay. So everybody got that right, hopefully. And why do you think they took this biopsy?
Like melanoma, rule out.
Yeah, rule out melanoma. So we see this, we see hemorrhage into the cornified layer, tail noir, rule out melanoma fairly frequently. Sometimes you get silver nitrate tattoos that can give you a blackish deposit in the cornified layer. Sometimes those henna tattoos can look, if you look really carefully, you can kind of see the pigment in those also. It's pretty hard to see the pigment in a henna tattoo, but we'll see those submitted as rule out melanoma and things like that on occasion. What organism causes this?
That's a great. I don't think it's a dermatophyte. I think it's like named wrongly. Is that correct?
Yeah, it's one of the dermatodiaceous fungal organisms. They change the names of those every few years. I think the one that they used to classically ask on the board examination was Cladosporium carrianii or Cladosporium ornicii. So Cladosporium is at least the genus that we learned. It may have changed, once they get a sexual stage, they will often alter the name, but know a few of those. It's just like a gimme. They'll ask you maybe a couple of questions on the board examination. Cladosporium, Alopecia boydii, Fonsecaia pedrosoi. Those are some of the organisms that generally cause the dermatodiaceous pigmented hyphae infections, like you see here. So like, chromomycosis, chromoblastomycosis, those kind of things. Make sure you know a little bit about those. This is in the same family of those entities. All right, so we have this one, and maybe we can get through this one before you guys have to go. So we've already done this, right? So what pattern We got a punch biopsy of
It's
we got granulomatous.
sarcoidal granulomatous.
Good. We got sarcoidal granulomatous again. What part of the body are we on here?
Trunk.
Mm. Notice this papillary dermis here is really loose. This is almost a myxoid kind of stroma here a little bit. And you don't really have much of a cornified layer, a little bit here, probably because it's been rubbed, but notice there's really very little granular cell layer here. So now what part of the body might you be from?
Myxoid,
Is this
I don't
like
know.
I was looking with all the muscle there, or like at the base, like that. I was assuming that wasn't like part of the reaction. That's just like giving the location at the base. Like, is it like mucosal or like
Yes, good.
genital?
Mucosal, excellent. Yeah, mucosal / genital, but actually it's got solar elastosis. So probably, unless they're a nudist, it's probably going to be like the lip or something like that, right? So we got sarcoidal granulomatous inflammation involving the lip. What's the most common entities that tend to cause that? We just already talked about it.
I mean, I know we talked about like foreign body granuloma. I don't know if you could think of like
Somebody said it
granulomatous
earlier.
cheilitis,
Somebody said it earlier. Remember?
sarcoid.
Well, yeah, obviously, but this one has a little bit more lymphocytes than we would like to see in sarcoid. So it's still sarcoidal pattern, but it's got a
Yeah.
little bit more lymphoid cells, and it's also on the lip. That's not the world's best place to get sarcoid, right? What if I told you?
Yeah, I guess. I mean, I guess. Sorry, what'd you say?
And what if I told you the person had a giant tongue as well? What do you think about?
Are we talking about like Crohn's?
Okay, you're in the family of Crohn's. The family of Crohn's. But what gives you the big lip that's swollen, the big tongue? You biopsy it and it looks just like this. What's that entity known as?
Is it like Melkersson?
Yeah,
Like granulomatous
Melkersson-Rosenthal. Melkersson-Rosenthal, the big tongue, the scrotal tongue, I think, is associated with it as well. And then you biopsy, it shows this. It looks just like Crohn's, basically. It's basically probably in the family of Crohn's, if you want to think of it that way. So, and this is the pattern of sarcoidal granulomatous dermatitis you see in those conditions. It usually has a few more lymphocytes like this. So that's in the differential. And this is an example of that. So when you think of sarcoidal granulomatous dermatitis in the mucous membrane, think of Crohn's, think of this entity, and chylitis granulomatosa. That's another entity. That's, again, probably Melkersson-Rosenthal without all the features of Melkersson-Rosenthal. They just get granulomatous inflammation of their lip. You guys talked about that granulomatous mastitis kind of thing. That's probably going to give you more of a suppurative granulomatous inflammatory reaction. But this is a non-infectious granulomatous process involving the mucous membrane. The only thing I would throw in the differential diagnosis is granulomatous rosacea. Perioral dermatitis can occur in the same location and can also sometimes give you sarcoidal granulomatous inflammation like this. So if you just saw a biopsy of this alone, you'd probably throw those things in the differential. Okay. Are you guys, you have to leave now, right? 7:45? I can do one more if you want. It's up to you guys. Tell me.
Sure, go ahead. People can go if they have to.
Pretty easy one too, by the way. So this
Okay,
is
there's
also
this
one of
dermal sort of nodule. And
so neoplastic, right?
yeah, it's a neoplasm.
Benign or malignant?
It looks pretty well circumscribed, but it's going
Good.
kind of deep. I don't know if we got the whole thing, but I think it's probably benign.
Good. Actually, yeah, probably benign. You know, we got 90% of it. And also if you do one of these kind of things, it's very symmetrical, right? So epithelial or non-epithelial? Or both?
I think it's both, actually.
Yeah, it's kind of both, isn't it?
Yeah.
It is both. And that's kind of helpful in this diagnosis.
Yeah, almost like a mixed tumor.
Yeah, it is a mixed tumor. And here you've got, what's the other name for mixed tumor?
Chondroid syringoma.
Yeah. Now, is this fit that chondroid syringoma pattern?
Well, there's the chondroid part.
Yeah, there's the chondroid part.
I think the
here's the
syringoma part is a little more over, but
Syringomatous part, right? I mean, they call it syringoma. It's really probably more of an apocrine adenomatous lesion with abundant hyaluronic acid that can undergo cartilaginous metaplasia. And so this is exactly what that is. This is a mixed tumor of the skin. So pretty straightforward, pretty easy diagnosis. And they probably would show you this, expect you to get it pretty quickly and move on to the next case. Is there anything about this that's, where are these mostly located in most cases?
I thought the face.
Yeah, head and neck area, and that's probably where this is. Got these large sebaceous lobules, but they're also located in the mucous membrane. And when they're in the mucous membrane, they're not really called the same thing. The dental oral pathologists, they refer to those things as adenomas, and they call them pleomorphic adenomas, and they're basically of the salivary gland origin. So you can have the type like this that occur in the skin, and then you can also get a similar lesion that occur in the salivary glands, and they can be actually sometimes comprised of mostly this kind of cell, and they also get they get biofibroblasts often in those lesions as well. If you stain those with actin, they'll stain positively, and some of those can actually become malignant. These rarely do in the skin. Any adnexal neoplasm in the skin, if you leave it alone long enough, can sometimes undergo low-grade malignant degeneration over the course of many years. And so sometimes we end up recommending excision, but the vast majority of them are benign like this. Any questions about anything we did today? Okay, well, thank you guys for attending, and hope this was educational for you. And
Thank you.
See you next time. Take care.
Thank you.